Hi everyone, this is Franklin Shi from Hong Kong, China. It is my great honor to present in the APOS session of the IOC Virtual Meeting 2020. The topic I present today is aggravation of gummy smile by strict wire mechanics and its management with or without orthognathic surgery up to 10 years follow-up. The presentation is based on an article which was co-authored by Dr. Raymond Chow, an oral and maxillofacial surgeon. In this presentation, I'm going to discuss the management of Miller and Forens. Both of them have gummy smile which got worsened by conventional straight wire mechanics. Although they have shown the same amount of gingival show, Miller was treated with surgery and Forens was treated with orthodontic camouflage with miniscrew assisted anchorage. I'm going to explain how does conventional straight wire mechanics aggravate gummy smile so that we can avoid this pitfall. I will discuss how to differentiate a surgical case from a camouflage case with the use of visual treatment objectives or VTO. I will also show you the results of long-term follow-up. Forens was receiving treatment from a general dentist and her gummy smile was getting worse. When she relaxed her lips, she was showing the entire clinical crown of upper incisors, indicating increased red incisal exposure and increased lip separation. She had convex profile and retrusive mandible. On the lateral shaft, which was taken at the natural head posture, her upper incisors are in front of the gall-line by Laurent angles, which indicates maxillary dental alveolar protrusion. Furthermore, the root apex of the upper incisors were outside the dental alveolar process. The distance between the upper occlusal plane to palatal plane was increased, which indicates total vertical maxillary excess. Panoramic radiograph. The shape of her condyles were normal. She had missing 2/8 and 3/8 and all first premolars. There were ceremometallic crowns at 1, 2, and 2, 2 to improve her pad-shaped lateral incisors. This is her 5 months after I took over her case. It was the time when she told me that I had restored her to how she looked before orthodontic treatment. What you can see is, before treatment, her red incisor exposure was increased, but it got worse afterwards. Her gummy smile also got worse after the previous treatment. So how did the previous treatment aggravate her increased red incisor exposure and gummy smile? If a patient has maxillary protrusion and excessive vertical growth of the upper teeth, which is called total vertical maxillary excess, by extracting first premolars for maximum retraction of upper incisors, the prolonged use of class 3 elastics during space closure would extrude upper incisors and rotate the occlusal plane in clockwise direction. Furthermore, as there is around 15 degrees of play between the 022 brackets and 1925 stainless steel arch wire, which is the thickest wire we normally use for sliding mechanics, the upper incisors tip back excessively, which again contributes to the extrusion. When the incisors extrude, they bring along the gingiva with them and hence worsen the gummy smile. Now, in the following presentation, I will focus on defining our treatment objectives and perform tests on VTO to see if the objectives comply with the biological limit of gingivae, alveolar process, and dental roots. I plan to reduce her 8 mm of red incisor exposure to 3 mm. I plan to reduce the 7 mm of lip separation to less than 3 mm. I want to reduce her gingival display from 6 to 2 mm and correct the maxillary dental alveolar protrusion. For the upper incisors position, if we use score as a reference, the upper incisors will be retracted 4 mm. As every 3 mm of retraction lengthens the upper lip by 1 mm, it will reduce the rest incisor exposure from 8 to 7 mm and gummy smile by 6 to 5 mm. However, by retracting upper incisors more than 4 mm, it reduces the bone support on the palatal side. Therefore, I plan to intrude the tooth by 4 mm, which puts the roots right in the middle of the bone support and reduce the rest incisor exposure further from 7 to 3 mm and gummy smile from 5 to 2 mm. Nevertheless, the occlusal plane now becomes too flat, which may affect the smile arc clinically and cause non-working side interference. Therefore, I plan to intrude the upper molars by 2 mm to restore the occlusal plane inclination to 7 degrees with reference to the horizontal plane of natural head posture. Upper molar intrusion would cause the counterclockwise rotation of the mandible, which improves the chin prominence and increases the overbite. To balance this, I had to bring the low incisors lingual and intrude 2 mm. The roots of lower incisors are still inside the bone, which comply to the biological limit. The planned incisor movement would close the residual extraction space. It also corrects the class 2 half units canine relationship. Now I'm going to talk about the mechanical tooth movement. In order to prevent the complication, we have to apply mini screws behind the extraction site to avoid excessive use of class 2 elastics during retraction. At the same time, we need a mini screw at the anterior region to intrude the upper incisors. Therefore, this is the standard appliance setup for correcting protrusion, which includes the use of a straight wire fixed appliance and mini screws at 1/6 and 2/6 mesiobuccal region and between 1/1 and 2/1. Nevertheless, in this case, we need 2 extra mini screws inserting at 1/6 and 2/6 distal palatal region and a palatal arch, as we need to intrude the whole maxillary dentition. Because of the time constraint, I will not be able to go into the details of biomechanics. Let's look at the treatment progress. I have replaced the brackets and inserted mini screw distal to the lateral incisors. Pouchings were used to retract and intrude the upper anterior teeth. Glass ionomer cement was used on the occlusal surface of lower molars to open the bite further. Now we can see that on the left that the mini screws were inserted on the 1/6 mesiobuccal and between upper central incisors, which looks like a standard setup to correct protrusion. But on the right side, we can see that pouchings were attached from the palatal arch to the mini screws on the palatal sides for molar intrusion. The space was closed and the case was deboned. Tracing of lateral ceph before and after treatment. Cephalometric superimposition, which showed that the movement was very similar to the PTO. Panoramic radiographs. No further root resorption was noted. We can see significant remodeling of the alveolar process after the treatment. Lower midline was slightly off. Buccal occlusion was class 1. On the left side, we can see more clearly the bone exostosis. The space was closed on both the upper and lower arches. Rest incisor exposure was reduced from 8 to 2 mm. Lip separation was reduced from 7 to 2 mm. Ginfold display at emotional smile was reduced from 6 to 1 mm. Smile arc was consonant with the lower lip. Profile was slightly improved. The 3/4 view shows that the upper front teeth and the dental alveolar process are harmonized with the face. Treatment time was 1 year and 10 months. She was followed up regularly for many years until her first baby was born and she gave up wearing retainers. I recall her 10 years later. The overjack increased slightly. Her profile hasn't changed significantly. The rest incisal exposure increased around 1 mm and lip separation was increased slightly. The gingival exposure was actually reduced over time. Overbites increased. Buccal occlusion was maintained. Clinical crowns of upper incisors lengthened slightly due to extrusion and also toothbrushing trauma. Some crowding of upper incisors as she gave up wearing retainers. Upper arch 1 was maintained. On the panoramic radiograph, we can see a localized resorption of the mesial side of the root of 1-1. It happened when the root was retracted into the nasopalatine canal. On the lateral side, we can see a large nasopalatine canal which opens to the incisive foramen. Saprophometric superimposition after treatment and 10 years later. Upper molars have extruded and the mandible has rotated back to where it was. Also, as we have seen on the clinical photos, upper incisors have extruded and the overjack was increased. Interestingly, her gummy smile didn't seem to get worse, which can be explained by the fact that the soft tissues changes, such as elongation of upper lip over time, offset the relapse of molars and incisor intrusion. On the other hand, the treatment at the time achieved the target we had set, and even after a decade, the improvement can still be seen. For Mueller, I plan to reduce her rest incisal exposure from 10 to 2 mm. I plan to reduce her gingival exposure from 6 to 1 mm. I wanted to improve her retrognathing mandible and protrusive lips. When we transfer the gore to the lateral septum, we can see clearer that the labial surface of the incisors is behind the gore, meaning I can't retract the upper incisors to help lengthening the upper lip to reduce the rest incisal exposure. Therefore, in order to reduce the rest incisal exposure from 10 to 2 mm, the upper incisors have to be intruded by 8 mm if it is to be done by orthodontic camouflage. Is that possible to intrude upper incisors 8 mm? Mechanically, it is possible, but biologically, the risk is too high, as you can see how much the root needs to travel through the bone. Let's look at the occlusal plane. By impacting the upper incisors surgically by 8 mm, we can see that the occlusal plane is too flat. Also, we have to improve the gummy smile at the posterior region. Therefore, the upper molars will need to be impacted 4 mm to restore the normal occlusal plane inclination. It causes a counterclockwise rotation of the mandible at its condyles to improve the retrognathing mandible, but it brings the lower incisors forward at the same time. Therefore, I have planned to retract lower incisors orthodontically 3 mm to restore the normal overjack. Now, the video shows that the roots are inside the alveolar process. If we compare the video of Mueller and Florence, we can see how useful the video is to differentiate a surgical case from a camouflage case. On the left, Mueller is a surgical case because the upper incisors have to be intruded 8 mm without any retraction. For Florence, the upper incisors are retracted 4 mm and intrude also by 4 mm, which is achievable for orthodontic tooth movement with skeletal anchorage. Let's continue with the objective setting. You may notice that the mandible is still retrognathic even after counterclockwise rotation. However, she is contraindicated to mandibular advancement surgery because she has idiopathic condyle resorption. She is safe to start treatment as her condition was stable. 1-4, 2-4, 3-4, and 4-4 were extracted. 4-7 was also extracted, which caused over-eruption of 1-7. I have planned to intrude 1-7, upright 4-8, and move it forward into the extraction space of 4-7 with minimal or C anchorage. The digital models in the occlusal view show the extraction space more clearly as the first premolar and 4-7 regions, which I have planned to close. Also, the mesially tilted 4-8. The right buccal view shows the over-erupted 1-7, which needed to be intruded to open the interocclusal space for uprighting and mesialization of 4-8. I plan to correct the half-unit buccal relationship, normalize the overjet and upright the retrocade upper incisors. Let's see the clinical progress. I have replaced the bands and brackets for the patient when I took over the case. 5 mini screws were inserted on the upper arch, just like the setup I have used in Florence case, but it was intended only to level the occlusal plane and intrude the over-erupted 1-7. As the leveling and alignment of the upper arch proceed, a cantilever was used to upright 4-8. We can see on the next slide that the tooth was uprighted. On the right side of the screen, continuous wire connected 4-8 to the rest of the teeth. On the left side, an opening coil was pushing the upper 3-3 against the posterior teeth to align the incisors in the middle of the alveolar process. Patient was then ready for surgery. Patient was back from 4 pieces segmentalization, and this was the time to proceed closing space of 4-7 from behind. On the upper arch, continuous wire was placed with the sliding mechanics in progress. On the lower arch, straight wire brackets were replaced with tip edge plus on 4-3 and 4-5 with side widers in place. On the occlusal view, the space at 4-7 region was closing. The patient was debonded with class 1 molar, premolars, and canines. This is the lateral ceph and tracing before treatment. This is the lateral ceph after pre-surgical orthodontics. We can see that the upper incisors were broken and the roots were brought back into the alveolar process. I did not intrude the incisal edge of upper incisors. Lateral ceph after surgery and debond. We can see very clearly the amount of impaction of the maxilla, setback of the upper anterior region, and auto-rotation of the mandible. Tracing of post-treatment lateral ceph and the superimposition before and after treatment. This is Miller before treatment. Look at the gingival margin when the lip was relaxed and at emotional smile, and compared to the next slide when decompensation was completed. Without intrusion of the incisal edge of upper incisors, but moving them labially, we can see how much the rest incisal exposure and gummy smile were improved by bringing the incisors close to the position before the treatment by the general dentist. 6 weeks after surgery, after debonding, before and after decompensation, 4-8 was uprighted, 1-7 was intruded. After treatment, 4-8 was moved forward to close the extraction space of 4-7. Before and after treatment, the lower midline was still slightly off to the left. Slightly class 2 buccal relationship. Space was closed on the lower arch. The upper arch form was changed and was more parabolic to match with the lower. Incisal exposure at rest and lip competency were normalized. Gummy smile was eliminated. Smile arc was consonant. Lower facial height was reduced, and the retrognathic mandible was improved nicely. Total vertical maxillary excess and maxillary protrusion were corrected. Treatment time was 2 years and 8 months. The patient attends my clinic once a year and she wears her retainers very diligently. On the right, it is the photo of 5 years retention. The occlusion suck-in improved and become more class 1. Upper and lower teeth were kept well aligned. Lip separation is more or less the same. The gummy smile didn't relapse. There's not much change we can see from the 3/4 view either. Post-treatment tracing was superimposed on the 5-year retention radiograph, which didn't show any difference. Thank you very much for your attention.